A 55 years old patient was ice skating and fell over the dominant hand with outstretched. Immediately, she complained of pain and the swelling. She was reviewed in A&E with right hand pain and the wrist close to her body. She was tentative and was quite reluctant to be examined. On assessment, there is swelling of the wrist. She has full sensations to all the fingers with good capillary fill. The radial and other pulsations are normal. The elbow examination is done, which is also non-tender. There is no pain in the shoulder with the range of motion or palpation. A standard 0P AP lateral and oblique radiograph of the distal radius injury gave a clue. Traction radiographs can assist in distal radius fractures to define whether the fracture is intraarticular or extraarticular, but these should be done in operative room under anesthesia because of the pain produced with traction. CT is sometimes helpful if the comminution is large, when the fracture fragments is difficult to visualize on plain radiographs. A three-dimensional reconstruction often makes the fracture look far more complex than it is. A diagnosis of an intraarticular distal radius fracture was made. When talking about intraarticular distal radius fracture, instead of talking about the Fernandez or Frickman classification, it is always better to talk about Malone classification. Malone classifies fracture based on 4 parts: shaft, radial styloid, dorsomedial portion, and palmar medial fragment. Classification is into 4 different types. Type 1 is 4-part minimally displaced fracture. Type 2 is carpal displacement, displaced anteriorly or posteriorly. Type 3 is a volar spike. Type 4 is a volar fragment, which can be palmar medial or a dorsomedial rotation. Distal radius intraarticular fractures are caused by shear from high energy trauma. The fractures are very important as they cause degeneration of the joint even if only a small amount of displacement is present. Treatment is dependent on the fracture pattern, degree of displacement of the fracture fragments, and the stability of the fracture. In our case, open reduction internal fixation was decided. Considering the fracture configuration, it was imperative to go dorsally. A longitudinal midline incision is made over the dorsum of the wrist, which provides useful and practical exposure of dorsum of the wrist and radius. The extensor pollicis longus is identified. The extensor pollicis longus is identified distally and traced to the 3rd dorsal compartment. This compartment is often distended from the fracture hematoma, and most fractures that split the scaphoid and lunate facet extend into the floor of this compartment, that is the 3rd compartment. This occurs because a strong and thicker lesser tubercle influences the fracture pattern. The 3rd and 4th compartments are sharply elevated off the dorsal aspect of the capsule with both the tendon compartments and the dorsal capsule ligaments, including the dorsal rheotracheal ligament, kept intact. Following this technique of incision over the EPL, avoid the need of repair of the extensor retinaculum and related compartments later. Swelling of the tendons and the joint capsule can make closure quite difficult. If the dorsal retinaculum is divided and not repaired, the tendons of the fingers and the wrist will bowstring with extension of the wrist. The EPL is translocated radially to allow visualization of the fracture. The joint capsule is incised transversely and closed later onto itself. In these fractures, a longitudinal hand table or traction or finger trap provide distraction of the joint and improve the exposures. Dental probes or small flare elevators can be used to align the fragments and reconstruct the articular surface. It is best to work from the deeper palmar portion of the joint to the more superficial ones. Small 0.8 to 1.1 mm KY are placed to provide support for the reconstruction of the articular surfaces. Bone substitutes or iliac crust bone grafts is placed with KYs for temporary fixation. The radial styloid height is maintained by a 0.06 or 0.8 mm KY out of the skin and bent to avoid migration. A dorsal plate may be applied now to beware of the tendon to avoid scarring. Immediate range of motion postoperatively is obtained if the fracture fragment and fixation is stable in the operative room. As we see in the hand surgery, sometimes a volar approach can be also possible. The hand is placed in longitudinal traction to obtain reduction. Reduction is obtained with muscle relaxation and manipulation. Fractures once aligned, we make incision using fluoroscopic guidance in AP and lateral planes. A Henry approach or a modified Henry approach can be utilized. A routine volar approach between the radial artery and the flexor carpi radialis is performed. We cut down through the skin and subcutaneous tissue. Meticulous hemostasis is obtained using bipolar cautery. The posterior sheet of FCR is also divided and the fracture is exposed. We do identify vena committions, keeping them in plain sight. Going into this interval under the radial artery, we take the FPL back out of our way. We easily see pronator quadratus and lift off the radius to directly visualize the fracture. The first step is to maintain the radial styloid height. This is maintained by a small K-wire of 0.062 inch. We focus then our attention on applying the plate to the fracture fragments and then fixing them with the plate. We make sure that the plate is as distal as possible to maintain the palmar tilt. We should also remember about the watershed area and avoid that as well. We are then able to drill and fill the screws. Closure is done by a 3-0 vicryl for pronator quadratus and monocryl sutures for the skin. The patient tourniquet is let down and good capillary fill is seen. A bulky dressing is applied. A Munster cast is applied for 3 weeks and an elbow range of motion exercise is begun. A distal range of motion is obtained immediately in the recovery room. And another alternate approach will be arthroscopic guided reduction. To minimize bleeding from the fracture site, which often obscures the arthroscopic field, the operation can be performed at least 3 days after the injury. A compressive elastic bandage is wrapped around the forearm to retard extravasation of fluid into the muscle compartment during arthroscopy. A traction tower with 10 pounds is applied to the index and long finger through the finger straps. An inflow canal is inserted through a portal located ulnar to the extensor carpi ulnaris tendon, that is 6U portal, and the joint is distended. Identification of the EPL and extensor regional communis tendon, a 20 gauge needle is inserted between them. This is the third and the fourth portal. The needle should pass easily into the joint without impinging on either carpal bones or the distal end of the radius to ensure that the arthroscopic cannula will not be inserted into the fracture plane or an intercarpal joint. Such as scapulonate or lunotriquetral joint. To prepare for the dorsal portals, make a skin incision over the dorsal 3-4 portal by pulling it again. This is the tip of number 1 scalpel blade and a blood arthroscopic cannula is inserted to prevent injury of the cutaneous nerves and dorsal veins. A small joint arthroscope 2.7 mm in diameter is inserted through the cannula into the dorsal 3-4 portal. For additional portals between the extensor digitorum communis and the extensor digiti minimi tendon, that is 4-5 portal, make an incision for the introduction of small joint shaver of 2.9 mm. A shaver is help clear the remaining hematoma and to provide a good view of the fractures. Mini graspers are useful tools when removal of loose fragment is necessary. Extravasation of fluids through the fracture and the capsular rent can cause troublesome soft tissue swelling, which can be minimized by allowing the irrigation fluid to exit through the arthroscopic cannula or a separate outflow portal. Using the maneuvers described above, fracture is reduced similar to the limited open approach. Smooth KYs are inserted percutaneously through the radial styloid process into the distal aspect of the diaphysis to provide the stable framework necessary for securing the remaining articular fragments. Using a blunt trocar, small fragments can be elevated beneath the fracture fragment with use of dorsal 4.4 or 4-5 portal or by means of large K-wire placed percutaneously into the metaphyseal bone proximal to the articular surface of the fragment. These wires can be then used to joystick to elevate and reduce the fracture fragments under arthroscopic control. Both the dorsal limb fractures initially are stabilized with a limited approach with use of buttress placed. Without visualization of joint surface, the fracture is reduced with use of only the osseous landmarks of the interdigitating fracture lines. To ensure the actual accuracy of the fractures, it is best controlled with arthroscopy and is adjusted as necessary.